Yeah.
Got it. Okay.
Nikki, do you want to handle the introduction?
I'm so excited to introduce one
Oh
of the
my God.
greatest educators in our program, Ken Steinberg. If you haven't heard of him before, he is our program director. So I hope that you know who he is. Really, Ken, you need no introduction.
Yeah, I know.
What else can I say? Ken is a pulmonary and critical care physician and works in the ICU and knows about the lungs. Thank goodness for that. Anything else I should say? In his free time, he enjoys reading a good book.
Yeah, and cooking food. Everyone knows I like food. So.
And eating food? Can I say that's my hobby, eating food?
Yeah, you can. Yeah. Yeah.
But we're so excited to have you, Ken, as a special surprise today. So I'm really excited for this talk.
Thank you. Well, thanks, Nikki and John, and hi, everybody. Yeah, it's actually right now, my favorite thing is I wish I could read a book. We are about to embark on reading Applications. Eris opened yesterday, and then there's a day or two lag while we modify our, individualize our system. And so we will be starting to read files. I also just got back from a little 3-day getaway to Bend, Oregon, which I highly recommend if anyone wants to go down there. But I am really all I want to do today. I got asked if I, could do a talk for you guys, and I'm not going to do a whole talk on diseases of the pleura and management of various things like chest tubes and, when to put in thrombolytics. That really is kind of a talk that dovetails with this. But for today, I really just want to review a bunch of cases that I found. I have these on my computer. Some of the x-rays are kind of old, but and I'll do some basic teaching about approach to analysis of pleural fluid. That's really sort of more what I'm going to talk about today. So we'll just go through cases. I didn't embed any quiz, type slides. So I'll need you to either use the chat. I wonder if I can show the chat. John, you may need to help me monitor the chat. I just opened my chat box, but it's and then or just feel free to unmute yourselves and we'll go from there. So let me, and now I lost my pointer. Huh. Here it is. Okay, got it. Let's see. Okay, so with those caveats, let me show you the first chest x-ray. And I'm curious what you think the cause of this pleural effusion is. Liver? Collapse. Oh, Liz got it. It's not a pleural effusion, is it? It's a trick. Let's see if I can, there's my laser pointer. This is a total whiteout of the right hemithorax. Exactly. Look at how deviated that trachea is. And the heart is also shifted over to the right. So I know we talk about this a lot, especially in the ICU, but when you see a total whiteout of one hemithorax, if there's something filling that space, it pushes things to the other side. If it's total collapse, it pulls things towards it. And I don't know if you can see this. This is subtle. Here's the trachea. Here's the left main stem bronchus. Where's the right main stem bronchus? There's actually a big giant turned out to be a mucus plug in the right main stem bronchus there, and total collapse. Okay, what's the cause of this pleural effusion? Yeah, I know, right? This is obviously from the Harborview ER, but you can see again the large opacification of the right hemithorax. The heart, if anything, the heart and trachea are pushed away a little bit. Here you see a pleural fluid line, and this is nope, not liver. This is a hemothorax. So, and we're not going to talk about management of hemothoraces, although you want to drain them so the blood doesn't clot in there. Josh says penetrating the liver. I don't know. That would be funny anatomy. Okay, on to the first case. So this is somebody that I saw in chest clinic many years ago, and a person in their upper 40s with a known history of breast cancer who came in with progressive shortness of breath. And I want to show this this X-ray for a couple of reasons. One is it doesn't really look like there's a pleural effusion, is there? But I don't know if you notice this, but the hemidiaphragm comes across kind of straight and then drops off. And there's this lateralization of the peak of the hemidiaphragm. Same thing on this side, although it has a funnier shape, it heaps up and then drops off. And if you do lateral decubitus films on this person, this is the right side down, and you can see the fluid coming up here, and then the left side down here. So there's bilateral pleural effusions, and this is actually what we sometimes refer to, the radiologists refer to as a subpulmonic effusion rather than the typical fluid, filling the hemithoraces. And every once in a while, you'll see this where the lungs just sit on top of the fluid, a subpulmonic effusion. And you can show that nicely with ultrasound or with lateral decubitus films. So before we dive into what's going on with this person, we'll just talk a little bit about normal pleural fluid. There's very little pleural fluid in each hemithorax. Some people estimate really only 8 to 10 milliliters of fluid spread around each hemithorax under normal conditions. And I know we think about pleural fluid formation being, kind of like when do you take out a chest tube? Well, when it drops below 100 cc's in 24 hours. But that's not even close to really normal pleural fluid formation, which is actually pretty low, estimated at 0.6 milliliters per hour. So really, 1 to 200 cc's of fluid in each chest. Wait, no, 0.6. Sorry, move the decimal point over. I can't do math. But somewhere, yeah, around 100 to. Okay, now I'm confusing myself. Yeah, it is about 100 to 120 milliliters in a day, and the normal rate of fluid removal parallels that, and so that you don't get accumulation of fluid. But if something happens in the pleural space and more fluid is entering, our normal physiology, we can increase the rate of removal by tenfold. So it really has to be that abnormal in order for pleural fluid to accumulate. When do we do a thoracentesis? You know, difference if you ask a pulmonologist from someone else. But normally, we say that the presence of a clinically significant pleural effusion, which is usually more than a centimeter, 10 millimeters thick, on ultrasound or lateral decubitus films with no known cause, if we don't know the cause. And so in some patients, we may not need to do a thoracentesis right off the bat. If a patient presents with CHF, an exacerbation of congestive heart failure, and they have bilateral effusions of similar size, they're afebrile, they have no chest pain, a trial of diuresis can be undertaken, and there's evidence for safety in this approach, because more than 80% of patients with pleural effusions caused by CHF will have bilateral, relatively symmetric pleural effusions. A thoracentesis probably is indicated if the effusion is unilateral and we don't know the cause. And similarly, if you initiate diuresis, there's good evidence that the pleural effusion should be coming down by 72 hours, coming down in size. And so if a pleural effusion remains unchanged despite diuresis, even in a patient with CHF, it probably warrants a thoracentesis. Similarly, I don't have a slide about this, but we've talked about liver and I love Josh's comment about, yeah, don't let the sun set on a untapped pleural effusion. We used to say that, but we see a lot of patients here at in our system, especially at Montlake, with advanced cirrhosis and hepatic hydrothorax, and that tends to be unilateral as opposed to congestive heart failure that tends to be bilateral, although there are exceptions to both of those rules. There are good data that show, though, that even a hepatic hydrothorax should be treated a bit like ascites, not a bit like, should be treated like ascites in patients who get admitted with decompensated cirrhosis or with fever, and you can get a spontaneous bacterial pleuritis. And so it is often indicated to do an initial diagnostic thoracentesis on those folks, much like we might do a paracentesis. Okay, let's move on then. The sun is about to set and we've tapped our fluid. And everyone knows we talk about transudates and exudates, and we make a big deal about this, and I will show criteria regarding that and data in the cases that I'm about to show. A transudate, another way to think about a transudate, is it implies there's really no disease in the pleura. It's extrapleural. It's an imbalance between hydrostatic and oncotic forces that we see in congestive heart failure, in cirrhosis, in nephrosis. It turns out PE, this was a surprise to me as I was looking some of this up, PE accounts for a reasonable number of transudates nowadays, in part because it creates venous back pressure. An exudate implies disease in the pleura. We came up with these words, transudate and exudate, but a transudate means there's nothing wrong with the pleura, and an exudate means there's something wrong with the pleura. There's either local disease or local inflammation in the pleural space that we see with infection, with malignancy, again, pulmonary embolism with infarcts now, or other inflammatory conditions. And so, as I said, a transudate occurs in one of two ways: the mismatch in hydrostatic and oncotic pressure, or direct communication is the other mechanism. And the common causes: heart failure, hypoalbuminemia, nephrosis, hepatic hydrothorax from cirrhosis, and then other hydrostatic causes, constrictive pericarditis, atelectasis with trapped lung, because it creates negative pleural pressure enough to change those hydrostatic forces. PE, SVC, obstruction. And then the really rare direct communication of fluid flowing into the pleural space, either from the dura or a central line, or the really rare urinothorax. I'm still waiting to diagnose my first urinothorax. Something that you've heard pulmonologists say a lot is, especially in the setting of hepatic hydrothorax, because patients can get dyspneic from those, we generally don't repeatedly drain transudates once we know, what the problem is. That's a general approach for all of this. Yes, a urinothorax is exactly what it sounds like, a connection between the kidney, I guess, and the pleural space. It's a fistula that forms sometimes in patients who've got chronic pyelonephritis or chronic obstruction. I know, look it up. It's in the literature. I've yet to see one, but nevertheless. Okay, so we're going to try to sort these things out. What do you order? Most of you know that we routinely order protein, LDH, glucose, cell count and diff, and a gram stain and a culture. Sometimes we order pH and cytology, and occasionally we'll order an amylase, an ADA, triglycerides and cholesterol. If you do order an amylase to try to look for pancreatitis associated or pancreatic pseudocyst associated pleural effusions, you probably should do an isoenzyme profile to differentiate it, just salivary amylase from pancreatic amylase. I'll touch on pH. You'll notice that a lot of the pulmonologists in our program don't recommend sending pH on pleural effusions, yet it's all over the literature. It's in UpToDate. And I'll show you pHs on some of these. I think it's fine to send. It's tricky to send. You have to send it in a blood gas syringe on ice, and sometimes the lab doesn't process it quickly. And so there's a lot of flop, if you will, in the measurement of pH. But again, depending on where you trained or where you go, or when you take board exams, they often will show you a pH. And we put these together, and I'll talk about some of the issues later. We talk about Light's criteria to help us differentiate. Richard Light at Vanderbilt University came up with these criteria many years ago when he was a pulmonary fellow, actually, to try and distinguish exudates from transudates. The whole goal was to help identify when fluid was exudative, when there was pleural disease. And these are the classic things: fluid to serum protein ratio less than 0.5 or greater than 0.5, LDH fluid to LDH in the serum ratio of 0.6, or the LDH greater than 2/3 the upper limit of normal. It also pointing to an exudate. And we think these criteria are magic. And in fact, they're really not that fantastic. And I'll talk later about some things that might actually be better. But here you see again Light's criteria and sensitivity and specificity for an exudate. And while these are good, they're not in the 90s. They're not that great in terms of specificity for an exudate. So I just want to plant that seed. I'll come back to that towards the end of the talk. Okay, back to that case that I showed you. Yes, John, they absolutely do. These criteria are on the boards, and they're clinically, we use them all the time. I'm not telling you don't use them. I'm just making sure you realize that there's, some wiggle room. Okay, so back to the case that I just showed you. That person that I had in chest clinic years ago tapped the fluid, and its appearance was serosanguinous. It had a normal pH, a normal glucose. LDH in the fluid was 305, LDH in the serum was 320. Protein in the fluid 5.2, protein in the serum 6.5. Red cells 86,000, white cells only 4,000, 20% monos. 20% polys, 74% mononuclear cells, 5% other cells, and the gram stain and culture was negative. And so I would classify this as a mononuclear predominant exudative effusion. Okay. Any concerns out there about what this might be? Person was afebrile, came into clinic with some progressive shortness of breath, history of breast cancer. Well, while you're thinking about that, yeah.
Joey put a guess in there. Joey says malignancy.
Yeah, exactly. Malignancy for 500. Yeah. Yes, unfortunately, this turned out to be a malignant pleural, a bilateral malignant pleural effusion from recurrent breast cancer. The leukocyte differential in exudates really helps us. And when it's neutrophil predominant, it's most likely to be parapneumonic or infected, an empyema, PE with infarction, pancreatitis, tends to be very inflammatory if it's neutrophil predominant. If it's lymphocyte predominant, it tends to be cancer, or if it's infected, it tends to be more TB or fungal pleuritis. But other inflammatory conditions can have a lot of lymphocytes, rheumatoid arthritis, sarcoid, the so-called Dressler syndrome, post-MI, post-Cabbage syndrome, chylothoraces. And then eosinophils in pleural fluid are pretty rare, but when they're high, yes, they can be parasitic or drug-related, allergic, but air and blood in the pleural space will actually sometimes attract eosinophils. So it's not always necessarily means there's a parasitic infection just because there's a lot of eosinophils. So we use that to guide our differential. And this person had primarily a lymphocytic exudate, and in the setting of previous history of cancer, and the cytology was positive. Cytology is positive in about 2/3 of malignant pleural effusions. Interestingly, if you do a pleural biopsy, it's actually you're less likely to make the diagnosis than just from cytology, because you may not hit the place where the metastatic involvement actually is in the pleura. And if you combine them, you get a little bit more sensitivity. The pathophysiology can either be direct pleural invasion, I typed effusion, but direct pleural invasion, and those often are bloody or serosanguinous, as in this particular case. Sometimes it's from more central lymphatic obstruction, and then it tends to look more serous. And the most common primary tumors to go to the pleural space: lung, breast, ovary, stomach, lymphoma, are things to look for. So that was a non-infectious, monocytic, lymphocytic, exudative pleural effusion. Okay, here's another person who came into the emergency department with progressive dyspnea, and had this chest X-ray where I think you can tell there's bilateral opacities and obscuring of the costophrenic angles, left greater than right, actually. And this one was tapped, and it was pretty serous, kind of clear, pH 742, glucose 85, LDH 95, LDH in the serum 205, protein 2.1, protein in the serum 6.8, very few red cells 86, very few white cells 600. Most of those 600 cells were mononuclear cells. Gram stain and culture were negative. How would you classify this? None. Maybe it has to do with the big heart. Yes. And this pleural fluid analysis, it has a low LDH ratio, a low protein ratio, a low total LDH, very few white cells, and it is in fact a transudative effusion. So great. Okay, so transudate, exudate. All right, this is an interesting story. This is a 50-year-old with a thrombosed left subclavian vein from a previous central line. Came in with acute dyspnea and pleuritic chest pain, and had this pleural effusion. And I'll tell you, everyone thought it was pulmonary embolism, and had this pleural fluid analysis. So it actually looked cloudy and kind of whitish in color, tannish white in color. I'll show you a picture in a minute. pH of 745, glucose of 95. The LDH in the fluid was 4,000, LDH in the serum 220. The protein 4.5, 6.3. So clearly both of those in the traditional exudative range. Not many red cells. White cells about 6,000. No polys, all lymphocytes. These turned out to 100% of those 6,000 cells were lymphocytes, and no other cells were seen. Any guesses just from that? Vicky says chylothorax. There's my hand holding the bottle of the chyle that came out of that person's left chest, and that clot had extended far enough down that it occluded where the thoracic duct enters and caused backup, this thrombosed subclavian vein, into the superior vena cava, and actually caused a chylothorax. And this was like the most easily treated chylothorax I've ever taken care of, because all we had to do was anticoagulate the person. And 3 months later, as the clot had resolved and now all the fluid could drain properly, it had cleared up. But chylous effusions do show up once in a while. There's sorry, what's that, John?
Sorry, wrong
Wrong
person.
thread.
Yeah, sorry.
Uh-oh. Yikes. Yeah. So lots of different causes for chylous effusions, and the literature is all over the place if you look up and try to read about them. In medical case series, the majority of them are from malignancy, either lymphomas or non-lymphomatous malignancies that occlude drainage of lymph from the lung, and you get backup and chylous effusions. 20% are usually from thoracic surgery with injury to the thoracic duct. I've seen case reports of people after pacemaker placement because of needle injury to the thoracic duct, develop chylous effusions, and a small percentage are trauma. Now, in the surgical literature, you can flip that all around, of course, so you have to be careful of the source. And then there are all these miscellaneous causes of chylous effusions. Here in our lung transplant center, you will see women with lymphangioliomyomatosis, and they often present with chylous effusions. Benign tumors, protein-losing enteropathies. You can see the long list, sarcoid, amyloid. You can see there's a long list of things that can cause chylous effusions. And the way we diagnose them, if they look the way that one does, it's pretty obvious. You want to see a triglyceride level greater than 110 and a cholesterol to triglyceride ratio less than 1. You want to see more triglycerides than cholesterol, because it's the triglycerides in chylomicrons that actually define a chylous effusion. The white cell count can be normal or in the range, sort of lowish range, and the majority of them tend to be lymphocytes. That's what's floating around in lymph, are lymphocytes. And if you had to, you can send the fluid for a lipoprotein electrophoresis, and it'll actually detect chylomicrons. The reason to talk about this a little bit is there is such a thing called a pseudochylous effusion or a cholesterol pleural effusion. These are usually due to chronic inflammatory exudates, most commonly with TB or rheumatoid arthritis, and in other parts of the world, paragonnomyosis, for those of you fascinated by infectious diseases. And in these effusions, it's a high cholesterol with a low triglyceride. And if you send electrophoresis, there'll be an absence of chylomicrons. Chylous effusions can be very difficult to treat if you can't treat the underlying cause. Many times, like in this case, all we had to do was anticoagulate the person and they got better. But for example, in women with lymphangioliomyomatosis, treatment of their lamb with sirolimus or with lung transplant helps. Sometimes you need to do pleurodesis to seal off the pleural space. But other times people are told to eat very, very low-fat diets and to try and minimize the absorption of chylomicrons from the GI tract. I've seen a few people who've tried to follow those diets, and it's actually quite hard. The MCT type diets. So, Lily, really great question. I don't know, in all honesty, of the efficacy of octreotide. Yeah, that's a really great question. So chylous effusions, pretty crazy when you go to tap somebody And yeah, it looks like, you know, propofol basically coming out of their pleural space. So, okay, let's go on. Okay, so here's a 38-year-old man who was admitted to Harborview. He had been intermittently homeless, had been working most recently down at one of the stadiums in the parking lot, and presented with 2 to 3 weeks of fever and not feeling well, non-productive cough, some night sweats, and then developed 3 to 4 days of right-sided pleuritic chest pain. And you can see this opacification on the right side of his chest. And it looks like there's pleural fluid. You can see fluid entering the minor fissure here. And so this is consolidation plus effusion. And there's on the lateral decubitus film, you can see the pleural effusion layering out really nicely on the right side. And here's the pleural fluid analysis. So I'll let you guys look at this and then maybe throw some ideas into the chat. Great. TB, get an ADA, any shelter use, TB, malignancy also. Absolutely. Good. These are great thoughts. And again, when I try to put words on these things, I find that it's helpful. And again, this meets the criteria for an exudate with a high LDH in the fluid and a high protein in the fluid. And it's primarily lymphocytic. And so a lymphocyte predominant exudative pleural effusion, cancer and TB, and some of the other things from the earlier slide there, autoimmune diseases can give you a lymphocytic predominant effusion. And in this particular case, we were, because of the indolent symptoms and the fevers and night sweats going on for a few weeks, and his history of being intermittently housed, we worried about TB. We sent off an ADA, and while it was pending, we did a pleural biopsy that showed granulomas in the pleural space. And so this person did, in fact, have a tuberculous pleural effusion. Now, maybe you've heard this already before, but most TB pleural effusions are not an empyema. They tend to be more of immune-mediated reactive pleuritis from the TB in the pleural space, from the granulomas in the pleural space. And it's really quite rare to have true pleural fluid infection that is like an empyema that needs to be treated aggressively like an empyema. The vast majority of these are free-flowing effusions that again have, you know, the cell count usually less than 10,000, mostly lymphocytes. Some things you'll hear people say, it's really rare to see any other cells. An absence of mesothelial cells has been associated in the literature with TB. And the smear, it's really rare. We send the fluid for smear, but it's really rare for the fluid smear to be positive, and even for the pleural fluid culture to be positive. Again, we send those things. We always send those things with TB because if you can culture stuff, you know, then you can get sensitivities, et cetera. But it's really pleural biopsy and pleural biopsy culture where most of the diagnoses are made in these cases of tuberculous pleural effusions. Yes, ADA is very helpful. A level greater than 50 is thought to be extremely sensitive for tuberculous pleural effusions, not specific. Some people with lymphomas and other lymphocyte predominant effusions can occasionally have positive ADAs. So be a little wary of that. But 70% of patients with TB pleural effusions, about 30% will resolve and they'll develop latent disease. But 70% of patients actually progress to active disease, and we treat them, as you're probably aware, as if they have active tuberculosis. So, oh, cool, octreotide. Nice. Thank you for that. I appreciate that. Oh. All right, so TB, another cause of lymphocytic pleural effusions. So, so here's the next one. This is a 49-year-old man, also intermittently housed, a history of alcohol use disorder, a history of intravenous drug use, and a smoker of a pack a day, and presented with relatively acute onset of dyspnea and fever. And, you know, very opacified right hemithorax, where you get the funny sense that there's just weird shaped things in there. And in fact, he had a CT scan that showed this, you know, loculated fluid collection, and had this pleural fluid analysis. The fluid was cloudy looking, and with a pH of 7.3, very low glucose, very high LDH, high protein, very high white count that was mostly neutrophilic now. So what are people worried about here? So now we have a neutrophil predominant exudative pleural effusion. And if you sent this for gram stain, it would have been, yep, this was an empyema. 4+ white cells on gram stain, gram positive cocci in pairs were seen on the gram stain, and it cultured pneumococcus. And so a pneumococcal empyema, gram stain positive, culture positive empyema. Now, here's another, just for comparison, here's another, I don't have an x-ray with this one. This was a really confusing one, in the sense it looked really cloudy when we tapped this person, and the pH was really low, like 6.25. That's like the lowest pH I've ever seen on pleural fluid. Again, glucose of 5, again, high LDH, high protein, only 180 white cells, and the lab said they couldn't really give us a diff. And yet on gram stain, 3+ white cells and 4+ gram positive cocci in clusters, and it grew staph. These white cells were all lysed. I don't even know exactly, you know, what does that other than bacterial enzymes, but don't always be fooled by a lowish white count. This was still an empyema. So, okay, I just showed that one. Now here's another gentleman who came in, 27 years old, fever and right-sided chest pain for a very short period of time, 2 to 3 days, and has this right-sided pleural effusion and consolidation, again, fluid in the fissure. Where's the foreign body? No, sorry, that's nasal cannula. Okay, good. Yep, you are losing it. Yep. Okay, and so this is another, what would you, so it's another very inflammatory pleural fluid. And again, I like thinking of, if just substitute the word inflammatory for exudate, a very inflammatory exudative pleural effusion, low pH, low glucose, high LDH, high protein, white count of 5,800, not quite as high, but again, mostly PMNs. And on gram stain, lots of white cells, no organisms seen, and the culture was negative. And again, this is a neutrophil predominant exudative effusion, gram stain negative, culture negative. This is what is called a complicated or complex parapneumonic effusion, and often treated very much like an empyema when it's this inflammatory with that low a pH, that low a glucose, that high of an LDH. That's just a very inflammatory process, even though it doesn't technically qualify for an empyema with negative gram stain, negative culture. So very similar complex parapneumonic effusion. I want to get to my last case, which is a fun one. This is a 27-year-old man with a history of Wilson's disease on penicillamine for his Wilson's disease. And he presented with 4 to 6 weeks of increasing shortness of breath, heaviness in his chest, and a right-sided pleuritic chest pain. And I don't have his x-ray for you, and I apologize for that. I tried to find it. But he did have a moderately sized right-sided pleural effusion, and we tapped it. And this is what showed up. It was serous sanguinous, more serous than sanguinous, but a little pink tinged, relatively normal pH, 734, normal glucose. The LDH in the fluid was 240. The LDH in the serum was 400. The protein in the fluid, 3.4. Protein in the serum, 6.8. 8,000 red cells, 7,000 white cells. Pretty, 30% neutrophils, 65% lymphocytes or other monocytes, 5% other cells. And so how do we classify this one? The LDH ratio is right at 0.6. I didn't make this one up, by the way. The protein was like right at 0.5. It had less than 10,000 white cells. Didn't have a lot of neutrophils. And so it's kind of hard to get a sense of what this might be. Anyone have an idea of another test we can send to help differentiate transudates from exudates? Lily, which lipid in particular? Triglycerides would tell us if this was a chylous effusion, and the triglycerides were low. And Kristen says a cholesterol. And yeah, we sent a fluid cholesterol, and it was elevated at 84. and the serum cholesterol was 212, but that's actually not even very specific. And I wanted to share with you these data from a paper in JAMA now almost 10 years ago, 9 years ago, coming full circle back to what we talked about at the beginning with the typical lights criteria. And now instead of sensitivity and specificity, Wilcox, who wrote this paper, had this column of either specificity or likelihood ratio based on pretest probabilities. And you see with the traditional lights criteria, the specificity was about 85%. That's similar to what I showed you on that very early slide for specificity for these criteria. With likelihood ratios of 7 to 9, and if they're all absent, a negative likelihood ratio of 0.04. So if they're all absent, pretty good that it's not an exudate. But they reviewed a bunch of other literature and found this, that an absolute LDH fluid level greater than 200 was better than the ratio in and of itself and had a very high likelihood ratio. But the single test that had the highest likelihood ratio for an exudate was the fluid cholesterol greater than 55. Some papers say greater than 60, but in that ballpark of 55 to 60 or higher, a likelihood ratio of greater than 20 with a specificity of 99% that this is an exudate. And this has changed my practice a little bit, and I'll come back to that in a minute. White blood cells, by the way, a low white cell count, unless they've been dissolved away by Staph aureus exotoxins, a low white count is very predictive of a transudate, but not always is helpful unless it's greater than 10,000 for an exudate. Anyway, I wanted to share that with you. And so this person had a high cholesterol. So this was an exudate that was, again, a lymphocytic exudate. And so we sent off some autoimmune stuff, and the ANA in the fluid was 1 to 240, which was even higher than the ANA in the serum of 1 to 160. The LE prep in the fluid, an old test actually, was negative. Anti-double-stranded DNA was negative, but the antihistones in the peripheral blood were positive. Anyone know what this is? The antihistone, drug-induced lupus. You guys nailed it. This was drug-induced lupus from his penicillamine that he was on for his Wilson's disease. Exactly. Good call, everybody. Yes, a really nice example of another cause of lymphocytic exudative pleural effusions, autoimmune disease, including drug-induced lupus. So very cool. That was cool, and got better off his penicillamine. So I think that just the absolute level, sort of as a pulmonologist, yes, I look at everything, but if the LDH is high and the cholesterol is high, it's most likely an exudate, and I don't have to do ratios in my head. And then if the white count's very low, with rare exception, it's most likely a transudate because it's not inflammatory. There's not disease in the pleural space itself. So back to this slide that I showed at the beginning, what should you order? Protein, LDH, glucose, cell count, gram stain culture. I've now added a cholesterol. I haven't found this in a lot of guidelines yet. People say, well, add on the cholesterol if it's a confusing picture. But it's a relatively easy test for the lab to do. And then all these others sometimes stay here. But I've moved cholesterol from occasional over here to almost routine. Yes, the likelihood ratio is extremely high, David. So, very sensitive, very specific test. So, and I'd have to look up, the numbers are presented in that paper and I could look that up. So
when a likelihood ratio is that high, it's almost certainly in the high 90s, 98, 99% on both sensitivity and specificity.
Oh, thanks, John. Yeah, there's our EBM expert. And so, Up to Date talks a lot about it as well. That's cool. Yeah, Lily, you and I are on the same page there. That paper has changed my practice. And there are so many times I showed you fairly dramatic examples of different things, but I'm sure you've all been involved in a lot of cases where the numbers are sort of close, or one's positive and the other one's not. And they've been on diuretics, and maybe the protein is, concentrated. And so then there was a paper, do you send albumins? Just send the cholesterol. Apparently, it's changed my practice. So, okay. With that, I just wanted to take you guys through, some cases that I've accumulated over the years. Thank you for your attention. Thank you for playing. Joey, I'll show you the money some other time. Yeah, just a fun bunch of cases. These, as John said, these will be on boards. They love putting fluid analysis stuff on the boards. And so I just thought it was fun to just keep showing you some. So, and as I said, I didn't really get into how do you treat these various things. That's a follow-up talk on what's the therapeutic approach to complicated pneumonic effusions and empyemas and things of that sort, because the literature has certainly evolved over the years. But I will stop now. Thank you very much. I've really appreciated your attention. Lipids criterion instead of lights criterion. I love that. Yeah, it still starts with an L. It's perfect. It's great.
I don't know if you can see, Ananyan's showing
I do.
the crew at one of the local coffee shops.
Oh my gosh, that's awesome. I hope you put cream in your coffee.
Yeah.
All right. Take care, everybody. Thank you.
Thanks, Ken. We always like having you come and teach us.
Oh. Goofy.
They posted that on the Instagram, so if you want to see them, they are on Instagram.
Cool.
Cool.
Buna coffee.
Yeah, I don't know if you've had it. It's really very good. Ken, for throwing it together, you sure did a great job. It was awesome. It was great.